Great. Thanks everyone for being here to join our seminar about the Biodesign Faculty Fellows and learning about their projects to design innovations to improve health and healthcare. To start off, I'd like to mention some upcoming MCHRI events. We have, first of all, the seminar series is really spearheaded by our education committee. It comprises of these individuals. We're very proud to have a cohort of very diverse individuals from various backgrounds that really lead the design and execution of this monthly seminar series, as well as our annual symposium. If you're interested in joining or becoming a member of our education committee, please don't hesitate to reach out to myself or any of the MCHRI team. Next, I would like to mention that we're really honored to present the Immunology of Autoimmunity and Antigen Presentation Symposium to honor the wonderful late Dr. Betsy Mellons. It'll be Thursday, May 1st. I'll share the links to all of these events shortly in the chat for anybody who'd like to register. She was such a star in immunology, and we're really honored to be able to present this symposium just to celebrate her work and highlight a number of her trainees and her colleagues. Next, we have the Stanford Medicine Children's Health Research Community event, co-hosted by MCHRI and the Clinical Research Support Office, or the CRSO. If you are a scientist or a researcher and you want to learn how to accelerate your clinical or your translational research, we'll be sharing so many resources and connections and opportunities at this event, and we really, really highly encourage you to come and attend. Lastly, our annual symposium will be on Wednesday, October 22nd this year. Please scan the QR code on this page, and I'll again also share the link in the chat shortly to register. And we welcome you and any community members to attend. This year, it'll be about maternal and fetal medicine and many innovations and research around how we're identifying early birth defects and conditions and methods that our researchers and community members are using to address them earlier on. Finally, thank you again for attending this symposium or this seminar. We're really excited to highlight the Biodesign Faculty Fellows, and I'll pass it over to Kunj.
Thank you. I'm going to go ahead and share my screen here. So every year, I think we have a session at MCHRI because of our continued collaboration and support from MCHRI about the Biodesign Faculty Fellowship. And we are now in recruitment season. And as a part of that, it's always great to have you guys hear from some of our recent fellows about the work that they have done. As you guys think about whether or not that's an opportunity that you guys would like to enjoy as well. When it comes to biodesign, just on a very high level, our purposes and values are these kind of 6 components really contribute to that. And we say collaboration, about doing everything together. That is so important in biodesign than I've seen like in any other area, is that it's really not something you can do alone. And you need a team, you need collaboration. That is something we have as an advantage being inside Stanford, that it's easy to collaborate without worrying about, who has the rights to this, who has the rights to that. It gives you an opportunity to collaborate really freely within the Stanford ecosystem. Innovation, we blaze through new trails in healthcare, diversity, integrity, and empathy, really understanding, I'd say keeping your focus on the patient and understanding their pathway through that is a key component. I'm sure any of the fellows can tell you, like I often come back to them like, okay, but how does this affect the patient? And then the last part is leadership. We strive to make a difference, both, in our own projects and then in others as well. And so with that, through Stanford Biodesign, we are continuing to reach patients through technologies that have been invented during Stanford Biodesign training. We're now up to 13 million patients, and this number, as you can see, has kind of growing exponentially every year because as we get farther and farther out with more inventions, that effect reaches more and more people. We've seen these metrics and they're constantly being updated and still out of date as we continue to grow, but there's been 56 companies that have come out of Stanford Biodesign with over 2,000 full-time employees, raised over 1.2 billion, and helped. This number is, as you can see, out of date because we previously just showed you the 13 million. So it's just continuing to grow. And these are a list of many of the companies, again, not all inclusive, of many of the companies that have come out of Stanford Biodesign, and we just want to continue to add to that and make this impact to patients all over. And as a pediatric specialist, I'm always focused on how we can make that impact in the pediatric and maternal health space, and that's part of why I'm coming to you guys today to share our experiences. It's something that is near and dear to my heart, and the more we can encourage innovation in this arena, the better. There's a vast opportunity in the pediatric and maternal health space, and there's a great need. So when we think about the Biodesign Faculty Fellowship, it really actually was fulfilling a need that was unmet within our biodesign training. I mean, for a long time, these were the different training programs available, all the way from the undergraduate level to executive education and global health programs. And yet we were missing one key component, and that was our faculty who had come here. They were recruited from all over, and yet we weren't really having a great way to integrate them into biodesign. And so with that, in 2014, we started the faculty fellowship. We mirrored a lot of this off of what we call the full-time fellowship, which takes 12 innovation fellows. Similarly, we take 12 faculty fellows every year and go through the entire biodesign process. And this is our class from last year. So you'll be hearing from 3 of our speakers here that are in this picture from last year's class. We are, now recruiting heavily for our 2025-2026 year. So we actually had an information session last week on April 9th. I will share the Zoom recording for that in the chat after, as we continue on, and we'll also be sending that out via email. Grant will be sending kind of a update email for recruitment, and that's just a nice, more in-depth view of the program itself. The applications will be due towards the end of this month on April 25th. It's a pretty short application. The key thing, though, is that you do need a signature from your division or department chair to support your application, and that there will be enough time for you to be a part of this fellowship and get something from it usefully, because we say that you need to commit about 10 to 12 hours a week to really get a meaningful change from this fellowship. And you can find more details on our website as well as biodesignstanford.edu and get to the faculty fellowship program. Just for a quick overview of what all our fellows do, and you're going to hear kind of the outcomes of that from our fellows in just a few minutes. The first part of the year, the fall quarter, is really more of a initiation and kickoff. We have a kickoff session in October and do a needs finding exercise during those times to actually understand like how to observe clinical medicine and actually identify needs, not as a clinician. If you are a clinician, you want to step back and really get to the observer side of that. So you can think of it, kind of putting your biodesign hat on. And then once we really get to a bunch of needs that you guys identify, we want to filter through them. We want to understand what are the best needs. You really have to kind of objectively compete your needs against each other so that you see where is the real opportunity for innovation. And this is in many ways like the secret sauce of biodesign. You'll work through parsing through those needs in the winter quarter, get to the point of identifying your final need. And then once you get to that point, you'll start brainstorming, thinking of concepts, solutions. But until then, it's really important to not think about solutions, because you want to really characterize your need up front without having a bias as to, I have this cool technology that I just want it to work. So we focus on that needs finding process a fair amount in the early half of the year. And once you've really gotten some of the concepts for how to solve this need, then we want to think about long-term commercialization. How do you look at this from a regulatory standpoint, reimbursement standpoint, business plan, and the intellectual property component? And so that's all of those things that you're learning during this period. And so the class workload is usually Wednesday afternoon or Wednesday evenings. 5:30 to 7:30 is usually the time. And we want to focus on, keeping that time really about your personal projects and getting more advice and mentorship. So the key is preparation in between. And that's when I tell you, you need the 10 to 12 hours every week. That's to prepare for this class. So that 2 hours of class is really focused on the progress you've made and what advice you can get from subject matter experts, what feedback you can get from our assistant directors, SMEs, from different faculty, from business coaches, and then you're going to also present to each other and get a lot of feedback through that process. One last thing with that is we encourage you guys to collaborate and have teams. We haven't really required that our faculty make teams, that they can work on projects themselves, just because we know that you guys are all subspecialized in your niche. But I personally am always in favor of collaborative projects. As I mentioned, this time commitment from January to May period, which is really the winter and spring quarter, is
Stay here, I'll be right back.
Sorry, what'd you say? Oh, okay. And that component includes the readings, the class, the project work that goes into it. And we will have, as I mentioned, the information session has already occurred, but we have a link for that I'll share with you so you can get some more details about biodesign and the process for BFF. Applications will be due here in just, I guess, just in 2 weeks on April 25th. And then our interviews will be taking place May 6th through 9th, and then we'll be able to announce our decisions by May 23rd. So by the end of May, you'll know. And this is really our BFF alumni cohort, which now has 121 people in it. And this year with our 12, actually now 13 faculty fellows, I'm really excited to say that 6 of them have a pediatric and maternal health focus. It's overall a really high number compared to in the past. And I'm personally very excited about it and just eager to see what changes and impact we can make. I am, as I mentioned, part of the leadership team. There's 2 other assistant directors. We're kind of the 3 coaches, myself, David, and Ashley, who are working with you guys in cohorts during the fellowship. And then we have our leadership team that has been working on the curriculum for years and been a part of this through and through. If you have more questions, feel free to reach out to me directly. You can also check out our website and we can go from there. And now, without further ado, I'd like you to hear from some of our alumni. I'll go ahead and start with Dr. Kathleen Kahn, and we'll basically have each of our alumni present the work that they did during our faculty fellowship. And then at the end, we'll have questions for everybody as a group.
Awesome. Thanks, Kunj. Let me actually pause my video so my computer doesn't freeze, and I'm going to share my slides. In the interest of time, I'm going to just talk briefly about, let me slideshow this, sort of my final project. Is this the...
We're seeing the PowerPoint view with your slides on one side and
I
note.
need to reverse it. With the notes, right? Yeah. Display settings, swap. How about that?
It's
Okay.
showing, oh yeah, now it's just a slide.
Okay, great. So for the interest of time, since there's 3 of us, I think in like 30 minutes, I'm just going to talk about what I did for my final project. I did go through the whole needs finding process. I did look at a host of clinical scenarios, like geriatric to pediatric. So really embraced the process. I am a pediatric urologist, and I will say after the needs finding process, it was a nice and pleasant surprise to realize that, what I thought is a big problem, both locally and nationally, is in fact a pretty large global problem. So it really helped me reframe, am I on the right track? Should I be focusing my efforts elsewhere? So I'm going to talk about bedwetting, which I think for most peds people is not a very novel concept, but I think when talking to a general audience can be. So, bedwetting impacts both children with embarrassment and shame, and then we really see that it impacts parents, right? So parents come into my clinic, into their PCP's clinic, they're really stressed. They're very anxious about this. This is a high burden of sort of sleepless nights and worry. Kids developmentally, right? They're dealing with like, they can't go to sleepovers, they've got to go home from school, or they're bringing a change of clothes to school. And there really is this sort of like cry for a better solution to bedwetting. And so part of this process, I think, which was really helpful, was to like put yourself in the shoes of many different folks who might be interacting with whatever ideas you're starting to think about, right? So who are all the different folks? Maybe it's the patient, maybe it's the family, maybe it's the PCP, maybe it's me, the pediatric urologist, maybe it's the insurance providers, right? Like put yourself in the mindset of lots of different folks. And so this is just an example of one of the exercises we go through, which is to say, like, what is the actual patient journey? What is the story that's really going to carry this forward? And for me, it was that this home experience is being relayed in a medical center pretty frequently. And then there are a lot of different out-of-pocket solutions, which create this like market, direct-to-consumer market for incontinence products for children. And then if you go further, you know, part of, I think, this process is also figuring out what is it? What's this thing that we're missing that might spark some ideas and creativity about how to address and think about better solutions. So for me, it was really thinking about, okay, what is the nitty-gritty of making this decision in terms of treatment for bedwetting? And one of the conversations that I have frequently is just, how often does your child pee? And families will say, I don't know. And I'll say, oh, I'll just fill out this bladder diary. And sometimes the kid hands it back to me like this. Sometimes the parents do it. And oftentimes they don't, which to me was an idea that I really sat with for several months and worked around, which is that our diagnostic ability is kind of limited. And that's seen in lots of different settings, both adults and pediatric. And I think there is some value to this in the sense that not all bedwetters are the same. And so I had to really think about like the mechanism, right? The like science behind what's going on, the clinical practice behind what's going on. And I basically said, look, I think in the realm of sort of like primary nocturnal, you know, monosymptomatic bedwetting, I don't think there are too many solutions that I can think of. And maybe in the subset of overactive bladders, I can like think about strategies and solutions. So this is just an example again, right? You're putting yourself in somebody else's shoes. You're really going into the literature about how have we been, what assumptions have we been making, and what other directions can we go? And so this is just an example of some of the slide decks that we present to make our argument. And I'm not presenting my exact solutions or anything like that today, but I think this table is really helpful because this is what I think I really got out of Biodesign, which is, okay, I've got a patient journey worked out. Okay, I've got a couple different ideas worked out that I could think about. Okay, now I'm gonna like play around with 3 to 4 different ideas, but now let's put them through the exercise of like, what are my technical limitations? What is my patent strategy? What is my regulatory obstacle that I'm sure I'll come upon at some point? And what is my ultimate business model? And again, because it's so iterative, you kind of like make these jumps in your learning during the program. You speak to different people about their experience and you realize, oh, I can read it in a book. And then if I go talk about it, I might actually realize it's something slightly in the middle. And then probably while I'm actually working on the actual idea, it might also shift as I gather more information. So I think that's the biggest thing I learned in this, which is that there are these different aspects of devices and solutions that I need to be thinking about and planning for, but that the networking and the text that we read really give you an idea of how nuanced this really can be in terms of a process. So that's me. I think we're doing questions at the end, so I'll stop sharing there.
Thanks, Katie. That was very insightful. And, you know, as someone that is a urologist, it was great to see you go through this process and think through where our, you know, potential blind spots are as we're looking at clinical needs. I wanted to pass it over to Matthew Muffly, who hopefully will be able to give his entire presentation. He is in the OR today. but he's one of our pediatric anesthesiologists. So I'll turn it over to you.
Okay, thanks, Kunj. So, yeah, I appreciate the opportunity to talk to you guys today. My name is Matthew Muffly. I'm a pediatric anesthesiologist, and I was part of the 23-24 Biodesign Faculty Fellow cohort, along with Katie and Meera. And Kunj, David, and Ashley were our faculty team liaisons, and they were fantastic. So, similar to Katie, I looked at a lot of different potential problems, and then I came back to this issue of how do we accurately monitor air going in and out of a patient's lungs, because this turns out to be kind of an important issue to understand, to be able to tell if someone's breathing, and it turns out that we don't have as good of a grasp on that as we might think that we do. So kind of walk you through some of the research that I did in the background, and then talk to you about the solution that we came up with. So here we go. I interviewed some of the members of our team, anesthesiologists and nurses, and the question was, how common is respiratory obstruction? And I hope you can hear this. Is there a lot of breathing obstruction in patients?
Yes.
Can you talk more about that?
They've been given anesthesia and the tongue falls back.
Is it like a day-to-day thing that you're dealing with?
Oh yeah.
Oh, yes, absolutely.
Do they ever obstruct?
Yes, the patients
How?
obstruct often, usually upper airway obstruction.
I've seen it pretty frequently here.
Yeah.
Like a percentage?
Like,
No, probably like 70%.
is it a day-to-day thing?
It's a day-to-day, yeah.
Every
Well,
patient?
no, it's every day. It'll
Yeah.
happen every day.
Yeah, so this is for patients who are anesthetized. It's very common that the smooth muscle, or the muscle in the pharynx and the mouth and the trachea just relaxes, and as they inspire, the tissues collapse. So it's a problem under anesthesia, but it's also a problem when patients or people are sleeping at home, just snoring. So it's a big problem. And how do we keep an eye? Breathing obstruction in patients? Oh, sorry. Sorry, let me advance. Okay, so how do you know if a patient's breathing? How do you know a patient's breathing? I look at their chest.
Sometimes I don't. It's the real answer. Color, pink. Where's the blue?
I listen if they're making funny sounds.
Well, it's usually like a process of elimination.
Good old hand in front of the mouth.
You can sometimes hear them breathing.
You look at them,
Okay,
you see if their chest is moving,
all right,
you put your ear next to their mouth.
yeah. Kunj, could you hear all that? Could you hear the video?
Yep, we can hear them.
Okay, okay, good, nice. So you can see, like, there's all these methods of detecting if someone's breathing, but they're all different. All different, and it's something that you wouldn't expect in 2025. How do you know patients? Oops. Okay, so we also have monitors. So back in the day, up to the 80s, anesthesiologists were using this device called a precordial stethoscope that went on the chest and went through this tube up to the patient's ear, or to the clinician's ear, to listen to every breath. But that kept you tethered to the patient, so it's kind of not a great solution. So the pulse oximetry is good. It tells you how much oxygen saturation is in the blood, but it's delayed by 1 to 2 minutes, so you don't detect that onset of respiratory obstruction. And exhaled CO2 is outstanding in patients, gold standard in patients who are intubated, but patients who are just in that not intubated or on the floor, so there's either it's not available, it comes off, or it's just not reliable. So for the Biodesign Faculty Fellowship project, we came up with this device that listens with microphones on the neck, on the trachea, and it sends a signal wirelessly to a standalone monitor, and that monitor reflects inhalation and exhalation. And so it creates this visual waveform of breathing. So it's a way to see breathing with our eyes, which is pretty nice because we like looking at waveforms. This is a picture, or this is a video of the actual waveform that's processed. And so you see these two humps, and the first hump is inhalation and the second hump is exhalation. So it's pretty nice how you can see both phases of the breath, and they're color coded and stuff. So that's sort of, after a lot of work, what we came up with. This is the team, or this pictures of various people who've been involved over the years. There's people from the Stanford Center for Computer Research in Music and Acoustics, the electrical engineering and engineering departments. There's graduate students, business students, other anesthesiologists. So we have a lot of people who've been involved, and it's been a really fun project. Had a great time working on this, and we couldn't have gotten this far without the help of the Biodesign faculty fellowship program, and also MCHRI actually helped us out quite a bit too. So yeah, I'm happy to answer any questions at the end. Thanks, Kunj.
Thanks, Matt. I think one thing you'll see, there's a lot of opportunity for kind of cross collaboration with MCHRI. I have personally experienced it too, where a lot of these biodesign projects, I've been able to get some early pilot grants with MCHRI and come back and forth. So there's just a lot of crosstalk and opportunity to get that through MCHRI, through other biodesign grants within the Stanford ecosystem. And so this is a initial launching pad. We often do offer some of our BFFs extension funding after the fellowship, but that's just like a bridge, and that doesn't necessarily mean one way or the other that this is a project to continue versus not. Many of our faculty have continued regardless, myself included, when I didn't get extension funding. So there's just many different opportunities available. I will now turn it over to Meera Sankar, who is one of our neonatologists that's also did our fellowship last year with this group.
Yeah, thanks, Kunj, for the intro, and thanks, Jessica and the MCHRI group for having me share this presentation. Can everyone see my slides okay? Okay. Yeah, so my biodesign project was very much in the newborn space. And so after the clinical observations, I had done several of them in the in different other specialties like surgery and anesthesiology. And finally, like I picked a project that actually was objectively that kind of topped the list, was newborn feeding. And so my project in biodesign, the faculty fellowship, was early detection of feeding issues in newborns to prevent readmissions. So I want you all to imagine a scenario. This is a common situation that happens for several of us in our, either to us or to our close friends and family. Here is a mom who's just delivered, and she's just been home for a day with her newborn, and the baby is starting to feed. He starts to lose weight, which is a normal physiological response. And and then as the days go by, he or she started to lose more weight, and the mom's trying to feed and her milk's not coming in. So this is a very common situation where the baby loses weight. And once the baby loses more than 10% of the birth weight, they started to have more difficulties with dehydration and jaundice. And then when the parents then take the baby to the pediatrician's office on day 3 or day 4, and then the baby has to be readmitted for either dehydration or jaundice. And this is a very common situation. I see a baby like this, even in the NICU, with really high bilirubin ranges, at least once, once a week, or sometimes even like, and in the nurseries, it's even more common. And so this is a project I really wanted to tackle. So why is it important? Because it affects term newborns who make up 85% of the total live births. And as we all know, like jaundice is a physiological response. 3 out of 5 babies get jaundice. And as I mentioned, it affects a lot of babies. 2 out of 5 can move into a high-risk zone. And it results in a 4% readmission rate. In addition to it's a big global problem because it can cause a lot of newborn deaths and also disability. The connectorus, which is staining of the newborn brain with the jaundice pigment, can be devastating and can cause neurodevelopmental disability, and it's easily preventable. And then the direct costs are very high as well. So I wanted to look at some of the pathophysiology first, address that first, where it could be maternal issues like history of breast surgery, difficulties with mom, like the first time mom, or, things like C-section. And then when the babies get dehydrated, here are some of the signs: a baby with sunken eyes, dry lips, and they have a soft spot that can be sunken. And there was also a skin turgor, which we sort of pinch the baby's skin on the abdomen, and you can see the tenting. And of course, if it's left alone, they can get a lot of other issues that can be very serious. So dehydration, again, can also result in jaundice. And again, the baby will look very yellow and refusing to feed, has less diapers and less urine output and less stooling. So when we looked at the what is available right now, there is a lot of support prenatally as well as birth to discharge. When they are in the hospital, the parents get a lot of support with hospital baby-friendly feeding practices, nursing, physician, lactation support. On the other hand, post-discharge, they're kind of left alone when they go home. And so I felt that there should be there is an opportunity here for us to provide targeted and timely support. And then I looked at the existing landscape, which is the number of apps that are out there in the market, some of these pediatrician visits or lactation consultant visits or telelactation. They did not satisfy all the must-have criteria, which are some of the usability and safety and cost and reduction of readmits in particular. So as we already know, like children are consistently underrepresented in the medical technology development area. That's why we're all here to talk about our pediatric projects. And the pediatric device market is growing. And so as you can see that in terms of the market size, it is almost $17 billion, and it's supposed to almost double in the next 8 to 10 years. So, and we also have the Impact One program that actually addresses specifically the pediatric needs here at Stanford. So that's great. So my solution is a personalized software app that the parents will be provided at discharge, and it will be configured with some maternal and baby data. And then we will expect the parents to enter a few data at home, which includes weight, feeding, and some voiding and stooling data. And then we will be performing a data analysis using a logic that's incorporated in the program that will categorize these kids into 2 or 3 different categories. And of course, the red category based on the weight loss and based on the other issues, feeding and so forth, will provide them with an immediate follow-up or prompt them to immediately follow up with an advice nurse or a pediatrician's office. And then if it is green, then they would be made to enter the data daily. So this was this led on to the FeedBridge project, which is in progress, using again the same thing that I described, but in a nicer, I guess, with a nicer in a nicer diagram format. So I think we felt that this solution would satisfy the decision makers on the left and the influencers such as patient and family on the right. And when I looked at some of the risk matrix, there was we still may need to look into the business model and the reimbursement concerns. And like we were hoping to mitigate risk by some of these starting off in the hospital and educating the nursing staff and providing getting some user feedback also from the parents as well as from the pediatrician and OBs. So I did partner with the Stanford Biodesign for Digital Health. And so in this winter session, the computer science students, they have a session called the Building for Digital Health, and they did build a FeedBridge app. So that is there. We are supposed to test this app in an informal basis, as well as next steps are to get funding and try to study this app in a more sort of hospital setting as a clinical study. And none of this is possible, as Kunj pointed out, this is full collaboration. So there is our biodesign team, and also there is the Stanford Biodesign for Digital Health team, and of course the MCHRI. So thanks to everybody for this opportunity, and I'm hoping that I could take this along further and provide an update later. Thank you.
Wonderful. Thank you all so much for your presentations and sharing your insights from your really innovative projects and the process that you've all gone through during the Biodesign Faculty Fellows program. We'll open it up to Q&A now. So if you have a question, please feel free to unmute yourself and share it verbally, or feel free to put it in the chat and I can speak it out for you. I am going to take this opportunity to ask the first question to take advantage of this moderating role and ask you all to share a little bit about your needs finding process and how you made the connections that you all mentioned explicitly or alluded to throughout all of your projects with the electrical engineering teams and the app designers and the other individuals and stakeholders that you interview to really fully understand the scope and the breadth of your need.
I can answer first, I guess. And again, I'll stop my video so that it hopefully comes through clear. I mean, I sent out a lot of cold emails. I think being part of the program really allows you to just put that at the bottom of your email and say like, hey, look, I'm doing this. This is legitimate. So that's how I first went through my needs assessment. I had a lot of phone conversations. I kind of stood, on the side in a lot of different parts of the hospital that I had never been in before, and people were okay with it because I had sent that email ahead of time. And then as part of my broader market research, as I was narrowing things down, that I started to reach out to the faculty coaches. I reached out to sort of admin folks at the hospital who I thought maybe could connect me to a better resource. So getting a little bit creative with just having a lot of different conversations and not knowing where they're going to lead, I think was really helpful.
I'll add to that. So I spent a good amount of time in the ICU on the patient floors. Oh, Meera's got to go. Bye, Meera. And just like Dr. Khan said, people were totally fine with me just being there. And then what I also found really useful was talking to people about their pain points. And they would just tell me everything. It was like a confession or something. So they tell me all about all the things that were just painful for them. And I thought that was really useful because we could then dig into these, issues. So I eventually came back to do an anesthesiology related problem, but yeah, I really found it useful to go and talk to a lot of different people. Oh, I guess I'll add, this is piggybacking on what Dr. Sheff said, which was we're at Stanford and there's a lot of different people and specialties. So I didn't even know that there was a Center for Computer Research in Music and Acoustics, but yeah, I just emailed them. I found out via Google emailed them, they got back to me, we met, and we've been collaborating for about 2 years now. So also the engineering, they're always looking for ways to collaborate so that they can get into spaces that they might not have access to. And that's so in medicine, they love, I think, getting involved in projects that bring them into the hospital and patients, near patients. So that hasn't been too hard, actually. They seem to really enjoy that. And I really enjoy, that's one of the things I love at Stanford here, is the ability to meet and work with different people all throughout the campus with different specialties and learning from each other. So that's my answer.
Can I ask a question? Is this the time?
Yep, this is the time.
In terms of, obviously there's a lot of internal Stanford talent and people and divisions that you can partner with outside of Stanford, people who have, either started their businesses, or other people in the community, not necessarily businesses directly related to biodesign, but sort of the concepts of, how do you get to that business stage to be successful there? Or just the interaction for the faculty fellowship, does it include meetings and discussions and kind of presentations, advice, scenarios, vignettes, whatever, from outside people who sort of have done this and may have some insights or recommendations for those who are early on in their path?
I can take on some of this question. So it's really a community, like within biodesign, and unlike a lot of other things where you're inside Stanford or you're outside Stanford, I feel like biodesign is extremely fluid. And the intent is that a lot of people are leaving after to start companies, and so it becomes this collaborative effect where people inside and outside of Stanford, if they're affiliated with Stanford Biodesign, it's like a route that, like, something that brings everybody together.
Yeah.
And so they've worked with Stanford at some point, and during the course itself, we have a lot of previous fellows and current innovation fellows that come back. So everybody is assigned like a business coach, an engineering coach. A lot of those people were previous innovation fellows or have taken companies forward or have that experience in the ecosystem. And then we also have like regulatory coaches and IP coaches and reimbursement coaches. So all of those people, while they're coming in for the fellowship, they are kind of agreeing to like all of, from an IP standpoint, like everything is inside Stanford. So there's no risk of talking to people outside of it. A lot of that also leads to having those relationships to talk to in the future. I think what I've done is reach out to different SMEs that I was paired with to get their advice. Now, you do have to be mindful and just like, put into place the fact that this is now a Stanford project, and that's like, there's some level of confidentiality there. But I think that this is a great starting point for connections. The other thing with advice, it really helps to have that biodesign name, because I can cold call, reach out to anybody that's done the program and working on a company or whatnot, and that tie really makes it easy to get advice.
Yeah. Okay. Thank you, Coach. That's a very good answer. Thank you. Can I ask you a question, Matt? You're and Kathleen, I know you guys are both busy clinicians working, take care of patients. You still smell like the sheep, as we say, right? You're still a shepherd taking care of patients, so you smell like the sheep. How was this in terms of sort of your impact on your professional thing? Did your division give you some allowance, or you just piled on everything else on top of it? How'd you guys work that out with your own division?
So I didn't have a clinical commitment reduction, but I did have a day, which happened to be Wednesday, off. So that helped because I could just go to the class on Wednesday. And then I just kind of piled it on, and I did some stuff on the weekends. But I think that 10 hours a week is pretty accurate. Yeah, yeah, I think it's pretty accurate amount of work.
Yeah, I shifted my research time to make it work. I didn't go down on my clinical work, but I shifted certain projects for that time period to other folks so that I'd have a little wiggle room. I would say near the end, especially when like that table that I showed for your like, that was all, each one of those was a coach, which was awesome. But then the coach is like, for me, I went and said to the coach, who are the like 3 other people that I need to talk to? So it generates, that's where the 10 hours comes from, because you'll go to that one session and be like, oh man, I really should talk to like 5 people. And so those conversations often happen. I mean, I would sometimes be driving and commuting and stuff like that, trying to get a phone call or a quick Zoom. So it's more the logistics of having those conversations that I think, especially near the end, I just needed to have the time to do.
And these meetings are all, most meetings are in person. They're not Zoom meetings. Is that correct? Or is it a mixture?
It's a mixture. I'd say about 40% are Zoom and 60% in person. We learned it used to all be in person. After pandemic, we realized there were some advantages, especially with like the subject matter experts, because you get access to more people with Zoom. But that just makes it all the more critical that all the in-person ones you guys are there for. And so we kind of give the list up front, with the expectation that you are committing to all the sessions.
Okay.
And it's available right now, the whole schedule for next year on our website.
Yep.
If there aren't any more questions from the audience, Kunj, do you want to wrap up with just if anybody's interested in the Biodesign Faculty Fellows Program, what dates and deadlines they should keep in mind, and how to reach you if they would like to ask further questions?
Definitely. So as I mentioned earlier, the applications are open. They are due April 25th. Again, it's a pretty short application. I'd say the most time-consuming thing is just making sure you get your department chairs sign off on this. For 2 components, there's obviously a small cost to the department for taking this, and also you want to have their buy-in for, it's not necessarily that you're like changing your whole schedule around, but it's just that understanding that you are committing time to this to begin with. I left my email here in the chat as well. If you guys have any questions, feel free to reach out. And earlier in the chat, I put in the info session recording. We're going to also send that out. I think Grant's going to send another last email, and we'll include that as well, because that's like a more detailed overview of the program.
Perfect. Thank you all so much for your time, for sharing your insights, for telling us more about this program. And we're really excited to continue this collaboration in the future.
Definitely.
Thanks, guys. Really great. Really appreciate your time and energy. Really excited to see what you guys are working on.
Thanks, Kevin.
All right. Ciao.
Bye for now.